This is the Inside Scope, and I'm holding here a stethoscope, which I have a trivia question for you. Out of all the many different parts that you see in this stethoscope, what do you think is the most important part? We're going to answer that trivia question in one of our future part podcasts, but I think it'd be interesting to find out, what do you think is the most important part? So give it a ponder, and we'll answer that in one of our future podcasts. Now, recently, it was Prostate Cancer Awareness Month, and prostate health may have been already important to you, your spouse, your parents, or someone you know. Or this could impact your life in the future because prostate disease is common. I'm here today with Dr. Greene, board-certified urologist and medical director of surgical and specialty services at the Hollis Cancer Center. Whether you're male or female, old or young, prostate cancer is something we want to learn more about, and it's best to hear it from the experts. Dr. Greene, welcome, and I know we've been raising awareness on prostate health, and I'd like to know, what are some of the updates? What are some of the new things we should be aware of?
We're going to take some time today to focus on the men. And some of the new things that we can talk a little bit about today that's out there that the public are hearing about is, how do we screen for prostate cancer?
That's a hot topic.
A lot of the primary care physicians now, with the challenge to get folks into urology or the comfort of interpreting the standard ways that we diagnose prostate cancer, is to get an MRI. So imaging, I would have to say, has been part of the algorithm to try to answer the question, what is the risk of prostate cancer? And is there enough justification to go into the next step to biopsy the prostate, which is the only way to diagnose prostate cancer?
I think that's what's been frustrating, and I really think the benefit is to sit down with an expert, sit down with a physician who's familiar with the topic. What are some of the common questions you get right off the bat from your patient? And then I have to ask, what do you wish the patients were ready to ask, and coming with these questions?
Well, my goal a lot with men is the basic screening question. Screening for prostate cancer is when men don't have any symptoms. So often it's just like the urgent care, or they go in when they're having symptoms. But the importance of detecting prostate cancer is a health screening, combining the test with an educated provider to do a digital rectal exam, that's a physical exam, a serum PSA, and then using those values to determine what their risk profile is. So screening for prostate cancer requires a blood test and a physical examination. But other things that go along with that, which is much more common, is their voiding function. How frequently they go to the washroom? Are they having trouble with storing or emptying their bladders? And the other thing that also that affects men as they get older is sexual function. So sometimes combining the two of them, getting them interested, getting them willing to go in and to share that with a provider is one of the biggest hurdles that we have in the community.
It's so important to have a medical home where you're going to a doctor regularly, you're seeing your urologist regularly, you're getting someone to know you. Now, for those of us that are listening that may not be as familiar with the prostate, where this is located at the bottom of the bladder, how big is the prostate?
Well, the prostate starts out in a 20-year-old male about 20 grams, and that's about the size of a small walnut. But it can grow over a period of time to being quite large, to 200 grams. So that's a factor of almost 10 or more. The size of the prostate doesn't influence the symptoms, so it's important, and it's discriminating the PSA whether or not it's important based upon the size of the gland. But where it lives is at the base of the bladder. The bladder's
right at the bottom of the bladder, and the urine tube, where the urine in the bladder, the urine tube has to go through the middle.
That's correct.
Prostate on its way out in men. Women don't have a prostate, so only men have a prostate, and this urine tube from the bladder has to go through the prostate. So as it grows, tell me a little bit about these symptoms that are not cancer, but it's just as we get old, the prostate gets bigger. What happens to that urine tube as it has to go through the prostate?
Well, the bladder and the prostate, it's a marriage of two organs. The bladder stores the urine, and the prostate's the front door. Mm-hmm. A lot of times we think that the symptoms like irritative, voiding symptoms, urgency, frequency is related to the prostate, but may actually be a manifestation of the bladder not being able to force the urine out.
Because it's a muscle.
It's a muscle.
And then I'm sure we'll have future conversations about urinating in women and having this issue of problems with lack of control in the bladder. But with men, that must really worry a man that they're having trouble getting the urine out.
No question. I think what really brings and gets folks' attention to go in to see a physician is the worry of going into a store and have to find a washroom, incontinence, leaking on themselves, or having wet pants or underwear afterwards because they're still urinating and they don't know it.
Or going and then having to feel like you have to go 15 minutes later. And as you were getting older, you want to plan trips, you want to travel.
Correct.
And you may be with a group, and the group had their bathroom break, and then 20 minutes later, it sounds like this could be really concerning. Do men often think, first off, oh, this new symptom could be cancer? Does that worry them right away, or have they already learned enough that a big prostate can?
It goes back to my comment about screening. Screening is an asymptomatic men.
Yeah.
So when men start to have lower urinary tract symptoms, irritative or obstructive, they think about cancer. But what I tell patients is that by the time they have those symptoms due to the prostate cancer, it's too late. So what that means...
Cancer is sort of a separate thing.
It's a separate thing. So the discriminator is that what's much more common in men is the lower urinary tract symptoms related to increased growth of the prostate over time.
Happens with age. So the prostate grows with age.
That's right.
You get these symptoms for the first time. A man and the family or the spouse may be worried that it could be cancer. It's typically not. It's the growing prostate. But you hit the nail on the head. It's a chance for a conversation, and you start that education on that first visit. To me, that's a wonderful conversation to be able to reassure someone. First, I'm glad you came in to see me. Second, we can examine and tell you, well, what's happening with your body, rule out your concern that it's cancer, and start you on a road to keep an eye on it. Do you worry about certain men that see you that you feel they have an enlarged prostate, which is part of aging, but you're also worried there's something about them that raises their risk for prostate cancer?
Well, the risks for prostate cancer are age, ethnicity, and family history.
What do you mean by ethnicity? Is it more common?
Race. So in different parts of the world, the incidence of prostate cancer are higher. So in Scandinavia, white men, the incidence is much higher in the general population there. In North America, African-American men have a higher incidence of prostate cancer. So based on those risk factors, positive family history, age, we factor in what the PSA is, the digital rectal exam, to then advise them of the risk and decide whether or not to go to the next step, which is a prostate biopsy.
Okay, and so even though it's private, it's sort of good to be able to have that conversation with family members, like an older brother, your father, grandfather. Do you find that patients, they know that their father had prostate cancer, or they don't know?
Sometimes they don't.
I know it's a private kind of thing, but I know my father had prostate cancer, and he was getting older. One day he just would not get out of bed anymore, and he would not say anything, and it turned out that it had already spread. And unfortunately, about a year later, he was stepping up, and just the weight of making a step up, the bone broke, the long bone in the femur. And it wasn't as if he fell and broke it. He broke it and then fell. But it was because the cancer had already spread at that point. And he was a very quiet person, never complained, retired sergeant in the military. And this thing just sort of came up without knowing it. Now, I don't know about his grandfather, but I certainly as myself. So you try to ask patients if they know their family history from brothers and uncles and fathers. Okay. What's the other issue that I thought it was really interesting that as the prostate gets larger, that those symptoms of having to urinate at night multiple times, those aren't necessarily symptoms of cancer.
That's correct. And some discriminating factors that getting up at nighttime is not usually related to BPH. It's physiological, meaning that laying down, so 2 to 3 times a night may be normal for the aging male.
Right.
We really focus on the daytime issues of
drinking a lot of coffee or drinks at night can add a little extra fluid.
So we take every opportunity, as you alluded earlier, education is power. So the more that you educate that patient on that first visit, they go home, they tell their family and others, and they bring back more information and they educate themselves.
So the second visit builds on the first visit.
But you have to build trust the first time. And so much for men coming in, the wives are often the one that will bring them in and force them. But once we get them, we try to dispel some of the myths that they have, including the physical exam, which is often a deterrent.
The blood test sounds pretty simple, but the exam where the physician respecting the person's privacy, giving a lot of explanation, and then being able to examine the prostate, men might be concerned. How do you handle that with a patient who says, well, I'll only want the blood test? And they may be missing some information, or...
Well, the challenging now with the MRI is exactly that. But as you train medical students and we went through medical school, we were taught the importance of physical exam. And so much of the public now through AI and think that most of the diagnosis can be done without physical exam.
Because the exam lets the physician get a sense of if there's a tumor. Is there a tumor, a growth, something that's there by actually being able, and we call it a palpation, but it's an examination.
Exactly.
And it's done through the rectum, and you explain to the patient that this is a normal exam. It doesn't take more than a few seconds, and move on. And then this is something to help say they're participating in their health and getting the best answers.
Well, I've spoken at the College of Family Physicians and try to educate primary care docs and stress the importance of physical exam of the perineum and doing a digital rectal exam for accurate diagnosis of testicular penile abnormalities. But I always tell them that 6% of colorectal carcinomas are within finger reach of the anal bird.
You're checking not just prostate, you're checking for colon cancer also. And recognizing that early, again, it may be not, you're really emphasizing the fact there may not be a lot of symptoms with prostate cancer.
That's right.
And it's the examination, blood test, maybe the role of MRI for screening.
The role for MRI, in absence of folks being comfortable doing the exam or getting the MRI. So evidence-based medicine and research is going to determine whether or not that's a reasonable tool to screen for prostate cancer. But if you recall, the definition of screening is low-cost, effective, predictive test that's going to discriminate cancer from not. And MRI is usually used for those that have failed the initial biopsy.
That's not a low-cost test. It's not takes quite a bit of time.
That's right.
It can have its own discomforts too. And
so MRI should not replace a good physical examination.
Exactly.
So in a screening for prostate cancer is a digital rectal exam and a PSA based upon the risk factors, age, family history, and ethnicity.
Okay, so you'll be able to get to know your patient. They may have raised concerns about the prostate. It may have been a non-cancer problem, but you're now opening the door for future screening based upon knowing your patient, their risk factors, the ethnicity, the family history. They may actually go home and ask their brother, do you remember if dad had cancer, if he had an enlarged prostate? So that's reassuring. What are some of the things you think about that happen next? What is sort of the common story as you get to know your patient over the years and they're visiting their physician and they're checking on a lot of things, blood pressure, diabetes, whatever but they're also keeping an eye on the risk for prostate cancer. What's the sort of a typical story that happens over time?
Well, for men's health, we do like to also address the issue of sexual function, because that usually goes in correlation with lower urinary tract issues and men's health to build their trust. And once you educate them, then you try to address some of the myths coming in. Some of the myths is that, what is a normal PSA? There's not such thing as a normal PSA. And
what is your PSA and what is it next year?
And what bears that is age, associated features that can cause the PSA to rise, such as a urinary tract infection, a big prostate, not emptying their bladder. So benign things that aren't cancer, can cause the PSA to go up. And to teach the patient, what is your PSA? What are the contributing factors? What about other things related to men's health that are important to them, even if not directly, but indirectly, if they're found to have prostate cancer, because many of those men don't want to go in and get checked because they've had an uncle or a father or family member in the community that had intervention and they were incontinent, they had sexual dysfunction, and their fear is so high that they don't even want to ask the question. So we have to dispel that fear.
Well, the thing is everybody's unique, is that they may have been talking about someone they knew. They also had diabetes, and diabetes might have affected the circulation, the nerves, and it may have added extra symptoms, sexual dysfunction, trouble urinating.
That's right.
And that's a unique story for that person. And with respect to privacy, let's have a private conversation with the patient. So you're there connecting with them, and also, gathering the information from other doctors they've seen. So it's good nowadays we have that good close communication. What else are you seeing as they move forward? It sounds like prostate cancer, to have symptoms from it, that's usually in a patient who hasn't been going to the doctor regularly.
That's correct.
I think that's what happened with my father, is he really didn't go to the doctor regularly, and he basically developed symptoms of prostate cancer because he never really had it looked at, and we didn't know. So I think that was one of the challenges. So if you're having symptoms from prostate cancer, it's probably been missed. What are some of those symptoms if somebody's not been checked? Because I know the treatment is where you show no matter what happens.
Well, you echo what I said earlier. By the time they get symptoms from prostate cancer alone, it's usually too late. Mm-hmm. So the reverse message is that significant prostate cancers that can threaten your life can occur without symptoms.
Okay.
So you
got to discover them early.
That's the issue with screening, because most men will come in with BPH, or benign prostatic hyperplasia, and a large prostate that will give the symptoms.
Trouble urinating.
That's the time that we get them and educate them about prostate cancer and rule it out while we treat their lower urinary tract symptoms.
Yeah, and answer their questions about other men's health issues. They'll have questions about testosterone level, or they'll have questions about muscle strength, and other things that affect, not just themselves or those that are close to them with that.
Correct.
Well, if prostate cancer is discovered early on, what are some of the treatments that move forward? Well, I guess one would be, if you think there might be prostate cancer based upon the blood test and the examination, how do you try to confirm? You said there was only one way to confirm if it really is prostate cancer.
So the MRI doesn't determine prostate cancer. An abnormal digital rectal exam, a nodule, doesn't mean prostate cancer. The PSA test doesn't mean it. So we use all those things and our clinical acumen to determine the advice to tell the patient they need a prostate biopsy, which is using an ultrasound as an imaging modality to guide a needle into the prostate and take strategic, that means specific sites.
So this is precision.
And
that to me, that's very reassuring as a patient, that I like hearing those words, is show me how this is precise, and it's used with a lot of skill. So,
and the majority of prostate cancers that are diagnosed today are with normal digital rectal exams. So what we're seeing is less issues of folks presenting real late with untreatable disease or end-stage disease. And screening and early, they're curable. So the whole thing with screening modality is that you can intervene to increase length of life and maintain quality of life.
Well, that's the best part about colon cancer screening, mammography, and prostate cancer screening, is you catch it early where you can cure it. And with the digital rectal exam, you can know precisely sort of where the area of possible cancer is, but it's the diagnostic test that, again, looks at the whole prostate and samples the prostate to look at it under a microscope. Is that they sample different parts of the prostate?
Right. You'll sample not only the abnormal area if it's there, but areas on the MRI if you get one that determine that. But we do a really strategic sampling of all the risk areas where the prostate cancer is. Then we hone in on areas of concern.
Okay.
So we like to minimize the biopsies to get the best answer up front to determine and to give the patient a stage, because everyone wants to know how bad is it.
Yeah.
So if you define, I'm going to do the biopsy, that's the next step. Then patients want to know what stage is it? Is it a tiger or a pussycat? And we can describe it in those terms. But then it's the Gleason's grade. It's a grade of that determine, again, helps determine the stage and the likelihood of it being spread.
So I'm thinking if this, being in the shoes of a patient, I'd be thinking, well, what's the size and what did it look like under the microscope? Was it like an aggressive looking cancer or a slowly growing cancer? What was the size? And has it or has it not spread? Are those those? So that's
what the patient wants to know.
You're really trying to focus on that, and that I'm sure determines the treatment. So what are some of the treatment options? How do they range through all that?
Right. Well, size, that you said earlier, is more the volume of cancer. You can have a huge prostate and only a small focus of cancer.
And it's a huge prostate because of other things in their life.
BPH.
Prostate has just grown big.
That's exactly
grown big. It's no longer a walnut size. It's gotten a little bit bigger.
So once we have the diagnosis of prostate cancer, we use the PSA, the results of the digital rectal exam or imaging, and the Gleason's grade to determine stage.
Okay.
And stage is usually the summation of, is it localized or is it spread? And then that is what guides the treatment options. So you can have a cancer that can undergo surveillance.
So this is the watchful waiting, where you sort of know your situation, but you're watching it closely. You're not going into actual treatment, certain.
And that's possible too.
Radiation treatment. So there are certain patients, and again, it's I think we talked about this earlier. What matters most to the patient and the family, and they may feel that in their life with what's going on, they want surgery or they want watchful waiting to keep an eye ready to go, helping them get educated. But it's like you said, it's what's unique about them that you give the best advice, so you share that decision.
Yeah, what we try to do is to give the patients an impression on the severity of the tumor and the impact, what they can anticipate for length of life and their quality of life should they do nothing or they intervene with therapy.
Yeah.
And then that helps them to rank their decision process that I usually go through them is that most patients want cancer control. The next is they don't want to leak. They don't want to be incontinent. The third is often sexual function. And the third is just quality of life. Some folks will not be content without cutting it out.
Right. They're like, I know I have a cancer. You've shown me the results. I want it gone. Versus another person might realize, well, to do that has its risks, but they understand the risks of doing something and the risks of not doing something and the benefits of doing something else and the risks. So those are great questions. Do you find that your patients are coming to the clinic appointments with great questions, or do you want your patients to be thinking of, specific questions?
Well, I think we can't expect that our patients know that, and what we have to do is educate the patient and the family members so that together they can help make the decision
and ask more questions
and how to prioritize. So what we don't do is say, here's your options, go home and call me back and tell me what you think.
Yeah.
They don't have that information. They need to be guided. They need to hear it 2 or 3 times. So the process is, and it's not right until they're ready. I tell folks that you'll know in your heart what you want to do, but until that period of time, we're going to sit down and we're going to feel comfortable about your cancer, your design, so that we can make the best long-term decision. And they're acceptant of the side effects, but it's often when you rush into modalities and they don't know that patients are more at risk of having an adverse outcome.
Now, if the cancer is discovered late and symptoms have developed, even though their chance for cure is lower, what are the treatments trying to do? I mean, I think that we all think about slowing it down, but how do you shift to saying, okay, well, here's your current situation and the unique things about you. How are we going to help someone where the prostate cancer has been found, late, discovered late? How can we help?
Well, when you look at the spectrum of folks that are diagnosed with prostate cancer, about 1 in 6 men are going to get it.
Yep.
So our goal as providers is to look at who are the folks that need aggressive local treatment because we're going for cure. Cure defined as never worrying about it, cutting it all out or treating it, and it's never going to come back. Versus the men that has metastatic disease and where it's
spread outside the prostate.
Outside the prostate, regionally.
The bone or lymph node. So there's little drainage areas like lymph nodes, and then there's the bones. I always heard of that.
So there is no cure for metastatic prostate cancer. So the goal is different.
Yeah.
Cutting it out, that's not what kills the patient. How do you manage metastatic disease? And the goal is quality and the maximum length of life. So you're looking for remission, you're looking for quality of life and getting length of life. But there's a whole other subpopulation of patients that we want to hit the home run with and cure them.
Cure them.
The younger guys.
That's
right?
a big message.
And even men in their 70s, folks that have 10 to 20 years life expectancy still want to have, and they need to be given the respect of saying, "Oh, you're too old. We're just gonna do something that's gonna put a."
Well, it's the whole
person discussion.
I think this because it really could impact whether it brings on feelings of depression, whether it changes how their relationship with the family, who's going to be very worried about all this that's happening. And these tumor cells, it seems that they're very sometimes responsive to things like hormones. And so some of your medicines are based to try to counteract that. So it's almost, would you call that chemotherapy, or is it?
No, hormone therapy, it's not even hormone therapy. What you're doing, you're blocking the brain's communication to the testicles that make testosterone to shut them down.
So because it's that causes the tumor to grow even faster.
One of the things it does. That's correct.
Okay, so you have these options to try to slow it down.
Correct.
Improve quality of life. That's a lot going on. Well, tell me about your team at the Hollis Cancer Center. That's located just south of Interstate 4.
On Lake Fields Boulevard. It's about 3 miles from the hospital.
Just north of the hospital, yeah.
That's right.
So the team there, and trying to get through with treating prostate cancer, it's not just, the surgical approaches or the radiology approaches. What are some of the team members that you have helping a person and the family?
What I think is very unique about Hollis Cancer Center and Lakeland Regional Health is that in supporting the community, we put the patient at the center of all our cumulative knowledge at Tumor Board. So it's like the center of the spoke of the wheel. So through that journey, they have the chance to hear different perspectives, mine, a medical oncologist and a radiation oncologist. So at the end, they're confident that they're well informed and they're getting the right decision. And that's what I'm proud of and confident and unique, I think, very much, and that's what the patients deserve, and that we take care of the family members and them. And that's what gives us such great outcome. So, and our mission is to put the patient at the center of all we do, and in an environment of education and discovery. So we're doing research. If there's new and better ways to treat prostate cancer, we're offering the clinical trials. If they need to know more about options, we're having community educational events so that they can understand what they can do to help through their journey, support their home and the patient, whether it's travel, helping them get radiation therapy or other things, whether it's dietary concerns. We offer that because that's the patient. It's that you treat it as a disease, and that carries over to Lakeland Regional Health. We have a wonderful surgical team, inpatient floor, where it's nice when patients come back and
their surgical team is great.
They're just they're like family.
Today, I think the key message was these screening tests, not just for prostate cancer.
And Dr. Haight, thank you for allowing me to have the opportunity to take the stage and say and emphasize again, screening is when you don't have symptoms. You need to go in, establish yourself with a provider. This isn't accomplished through urgent care because lung cancer, colon cancer, they don't present with symptoms.
And there is screening for lung cancer. If you've smoked cigarettes for many years, we hope you quit. But if you've been smoking cigarettes, there's lung cancer screening, there's colon cancer screening. And I think, wow, it's so important to know your family history, because when you get the screening is based upon your family history. And same thing with diabetes, but with cancer, the prostate screening, since it's such a sensitive topic, I think you hit the nail on the head. Get to know your doctor. Have these private conversations that you feel comfortable asking questions, and they will certainly do what you said. Right. Bring it up and say, hey, we need to do these screening tests to keep you in the best health.
Screening is what saves lives. We can help folks deal with cancer when they have it and do that effectively. But if we really want to make a difference and save lives, then screening is important.
Earlier the better. Thank you very much. I appreciate that. That is great information.
Thank you.